In patients with severe chronic kidney disease presented with non-ST elevation MI, revascularization was associated with a lower risk of both in-hospital and long-term mortality. However, the risk of in-hospital newly initiated hemodialysis was increased. For those who survived to discharge, the risk of progression to chronic hemodialysis was also increased. This information could be provided in the process of shared decision-making. My name is Xiaofu Zhi. I'm an assistant professor in Chang'e Memorial Hospital, Taiwan, giving a summary of our article, Revascularization in Patients with Non-ST Elevation MI and Advanced Chronic Kidney Disease. This article will appear in the upcoming issue of the Mayo Clinic Proceedings. Revascularization has been shown to be benefit in patients with non-ST elevation MI. However, patients with advanced CKD and presented with non-STEMI, they were more likely to be treated only medically, mainly in concern of contrast-induced nephropathy. In addition, data regarding the clinical impact of revascularization in patients with non-ST elevation MI and advanced CKD remain inconsistent. 2,800 patients with advanced CKD, defined as eGFR less than 30, including 40% of the patients under chronic hemodialysis. They presented to the hospital with acute non-ST elevation MI, and they were retrospectively identified from a multi-center database in Taiwan. 40% of the patients underwent revascularization, including 91% of them had received PCI. Patients in our study were about 70 years old, 55% of them were male, and 55% of them had diabetes. 1/3 of the patients had unstable hemodynamics, requiring medications, IABP, or even ECMO. And 1/3 of the patients had respiratory failures. Patients who underwent revascularization were younger, and more of the patients in this group had non-CAD, prior PCI, or under chronic hemodialysis. Prior stroke, dementia, and cancer were more prevalent in patients who received only medical therapies. We use inverse probability of treatment weighting to generate two comparable groups, the revascularization group and the medical therapy group. Revascularization was associated with a significant lower risk for in-hospital and also long-term all-cause mortality after a mean follow-up of 1.8 years. However, revascularization was associated with an increased risk of newly initiated hemodialysis before hospital discharge. Among those who survived to discharge, revascularization was also associated with an increased risk of progression to chronic hemodialysis. These findings were consistent, irrespective of the presence or absence of diabetes, heart failure, chronic hemodialysis, or unstable presentations. Shared decision-making is important in clinical practice. The choice between treatment in favor of longer survival or longer hemodialysis-free interval may depend on age, frailty, comorbidities, and economic burdens. Future randomized trials are required to further corroborate the findings of our retrospective analysis. Thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.